Hi guys, I'm Dr. Parvez. I'm Dr. Parvez Ahmad Rishi, and I have done MBBS and MS. I'm pursuing. Today's topic is otitis externa. It is inflammation of the external auditory canal, localized otitis externa, folliculitis that can progress to a furuncle, diffuse otitis externa, more widespread inflammation, example swimmer's ear. Otitis externa defined as acute if episode is less than 3 weeks, chronic if greater than 3 months. So, if one episode lasts for 3 weeks, it is acute episode, and if it lasts for greater than 3 months, then it is chronic otitis externa. Malignant otitis externa extends to mastoid and temporal bones, resulting in osteitis, typically in elderly diabetics. Suspect if pain seems disproportionate to clinical findings. Localized otitis externa causes usually infected hair root by Staph aureus. Symptoms: severe ear pain compared to size of lesion, relief if furuncle bursts, hearing loss if EAC very swollen. Signs: tiny red swollen in external auditory canal early, later has white or yellow pus-filled center which can completely occlude EAC. Management: analgesia, hot compress, antibiotic only if severe infection or high risk patient, flucloxacillin or erythromycin. Refer if needs incision and drainage. No response to antibiotic or cellulitis spreading outside EAC. Acute diffuse OE causes bacterial infection, Pseudomonas, Staph aureus, seborrheic dermatitis, fungal infection usually Candida, contact dermatitis, medication sudden onset, or hearing aid, earplug, insidious onset. What are the symptoms? Any combination of ear pain, itch, discharge, and hearing loss. These are the symptoms of acute diffuse OE. Pain, itch, discharge, hearing loss. Signs: external auditory canal and external ear are red, swollen, eczematous. Serous, prolonged discharge, inflamed tympanic membrane may be diffuse, difficult to visualize. Pain on moving ear or jaw. Investigation: rarely useful, but if treatment fails, send swab for bacterial and fungal culture. You can see in the diagram. Management: use topical ear preparations for 7 days, 2% acetic acid for mild cases, and antibiotics plus steroid, example locotin, Viofoam, Gentisone, hydrocortisone, Gentisone hydrochloride. Not if perforated, not if there is perforation. If wax debris obstructing external auditory canal or extensive swelling or cellulitis, Popewick, dry mopping in children, microsuction, ANT, PCC. Advise a prevention of otitis externa. Keep ears clean and dry. Treat underlying eczema, psoriasis. Failure of topical meds. Review diagnosis, compliance. Consider peroral flucloxacillin or erythromycin. Fungal, spores in external auditory canal. Swab and refer. Chronic otitis externa causes secondary fungal infection due to prolonged use of topical antibacterials or steroids. Seborrheic dermatitis, contact dermatitis. Sometimes no cause can be found for otitis externa. And what are the symptoms? First symptom is mild discomfort. It may lead to pain, usually mild. Then what are the signs? Lack of airwax. There is no airwax and air is dry. Hypertrophic skin leading to canal stenosis. Pain on examination. Assess risk precipitating factors. Severity of symptoms. Signs of fungal infection. If there is whitish cotton-like strands in EAC, black or white balls of aspergillus, look for signs of dermatitis, evidence of allergy, ear plug, etc., or focus of fungal infection. Elsewhere, example see skin, nails, vagina can cause inflammation of external auditory canal. Investigations only take swab of culture and sensitivity if treatment fails, as interpretation can be difficult. Sensitivities are determined for systemic use, and much higher concentrations can be achieved by total by topical use. Organisms may be contaminants, usually fungal overgrowth after using bacterial drops due to suppressed normal bacterial flora. Chronic otitis externa management. Advise general measures as for acute diffuse otitis externa. Treatment depends on cause, often requires more than one strategy. If fungal infection, top antifungal, topical antifungal, refer if poor response. Seborrheic dermatitis, antifungal and steroid combined. If no cause evident, 7 days course topical steroid, plus minus acetic acid spray. If good response, may need to continue steroid but reduce potency dose. If cannot be withdrawn after 2 to 3 months, refer to ENT. Uh, it means refer to higher position. For example, resident will refer to consultant, or consultant will refer to head of unit, head of department. One department will refer to another department, and finally it will be treated by ENT. If poor response, try trial of topical antifungal. Refer ENT if contact sensitivity, repatch testing. If EAC occluded, if malignant otitis externa suspected. Thank you, guys. Please like and subscribe to encourage us. Thank you very much.